So I think you all probably know, unfortunately for you, who I am. These are my disclosures, and the most relevant one here is that I'm the chief investigator in the UK for the NeVa NeVa registry. So the things that I'd like to discuss today are actually sort of the background, give a bit of the story around mechanical thrombectomy and then around the device. So what is it that we know so far about clots? And we're lucky to have one of the experts on clots sat here at the front. What do we know about how stent retrievers interact with clots? What are the challenges that we face? And what does the NeVa device offer to deal with these day-to-day challenges? What about the NeVa NET? And what is our experience so far in London? So the red, the white, but all ugly is basically how I think about most clots nowadays. So thanks to Tommy and a few other people around the world now, there's been a lot of work done on clot histology. And what we're learning is that not all clots are the same, they're not equal, and in fact they have a very heterogeneous makeup. Principal components contain or consist of red blood cells and then platelets and fibrin. To a lesser degree, you have von Willebrand factor, and we heard a fantastic speech from and talk from one of the world's experts, Simon de Meyer, on this very topic yesterday. In addition to von Willebrand factor, you have leukocytes, and then you have DNA and neutrophil extracellular traps. And these are all components of an ongoing immunothrombogenetic problem. So a very nice paper done by a couple of very handsome, very intelligent people. You can see Tommy Anderson, Simon de Meyer there at the end, as well as Senna Stasens that was mentioned earlier, published last year. They analyzed 177 thrombi collected from AZ Groninger Hospital. The clots were immediately placed into paraformaldehyde for 24 hours and then sectioned. And they did what many studies unfortunately haven't done in the past, which is in addition to standard staining, they also did immunohistochemical and immunofluorescent staining to allow them to elucidate the von Willebrand component, von Willebrand factor component, fibrinogen, as well as determine leukocytes. And what they showed was that you have RBC rich and fibrin poor, and then RBC poor and fibrin rich clots. But you only really find platelets in association with fibrin, so what you can deduce is that these are RBC rich platelet poor or RBC poor platelet rich clots. And this was a diagram shown by Simon yesterday. But even once you take into account the overall architecture of an RBC-rich clot or a platelet-rich clot, actually there's still a little bit of heterogeneity within the clot architecture itself. So the RBC-rich portions of a clot are actually composed of homogeneously distributed and tight, densely packed RBCs that actually sometimes alter in shape. And they're surrounded and contained within a very thin fibrin network with no other significant structural components. Whereas the platelet-rich regions contain virtually no red blood cells, but dense, thick fibrin formations, von Willebrand factor, and just packed full of platelets. And you can see the difference in the diagrams here, or the studies rather. So here you have lots and lots of densely packed red blood cells, a thin fibrin network, and then overlaid on top. And the interesting thing is here is within the same clot you have platelet-rich, very dense fibrin network, and then red blood cell rich areas next to each other. And there's probably differences in stress and strain within clots dependent on which type of clot you have, and we're going to come to that shortly. Leukocytes and NETs are found associated with the platelet-rich thrombi and platelet-rich regions, but not with red blood cell-rich regions. Some thrombi actually had very rich cores that were red blood cell-rich, but were surrounded by platelet-rich shells, and that effectively protects the red blood cell-rich core, like an eggshell, from intravenous TPA and other drugs. So who cares? Why are we talking about this? Because, as we now understand, the mechanical properties of red blood cell and platelet-rich clots vary and are quite different. Boudet et al. Have recently performed some compression tests on retrieved thrombi, and again, Simon was involved with these studies, and no doubt Tommy had a hand in the background there as well. So they, from clots taken from patients, sectioned these clots into 1 millimeter thick slices. And if you had a long clot, 5, 6, 7, 8 millimeters long, it was multiple sections. So it allowed a more accurate assessment of the stresses and strains and the compressibility of the different regions within the same clot that's been removed. The overall thrombus composition you could see is somewhere in the middle of that graph that we showed earlier, slightly more predominant fibrin and platelets, but kind of an average clot, let's say. The median thrombus stiffness here was 560 kilopascals, but quite a broad range of stiffness, going up to close to 1200. Now, essentially what they showed was that an increase in fibrin and platelet content caused an increase in the stiffness. So for every 1% increase in fibrin platelet content, you had an increase in the stiffness of the clot by approximately 9 kilopascals. And you had the converse, actually, with red blood cells. So an increase in the red blood cell content resulted in the opposite effect, so a decrease in the stiffness. But interestingly, what they showed was that there seemed to be an inflection point at approximately 70% platelet rich. So here you can see that as the red blood cell content increases, the stiffness of the thrombus decreases. But what you also see here is that actually at roughly 70%, you start seeing an exponential rise in the thrombus stiffness when you get to 70% platelet fibrin content. And you can see both on univariate and multivariate analysis, very significant changes there. And what these authors noted was that the implications of this is that it's harder for a stent retriever to penetrate a fibrin and platelet-rich thrombi, and this has been suggested by other people. And so one of the things that they said, and has been discussed previously many times, is that perhaps you need stent retrievers with different mechanical properties and physical properties, perhaps with larger radial forces to handle these very platelet-rich thrombi. It's also been shown that the clot friction increases as the red blood cell content decreases, but also as the platelet and fibrin content increases. And again, once the red blood cell content decreases to approximately 20% or below, you start seeing very significant changes in the amount of clot friction between the clot and the vessel wall. So what you can see is that essentially the sort of 70 to 80% platelet content seems to be some sort of critical value, and why that is, I think, is still under investigation. Numerous studies have shown that platelet-rich thrombi are harder to remove, and this is continuing ongoing work from many groups around the world. You can see here that the TICI-2B scores after are slightly poorer for platelet-rich white clots, and also you need an increased number of passes. So more passes are required to effectively get slightly worse TICI-2B3 scores. So overall, it's tricky. And if we factor in what we learned from Jens yesterday, what you really need to do is get everything out as best as you can within 3 passes at maximum. So in summary, so far, what we know is that white clots are less dense on non-contrast CT. They tend to be smaller. And one study has been published that demonstrates that white clots tend to be about 9.5 millimeters in sort of median length, whereas red blood cell rich clots tend to be about 12 to 13. So a little bit longer the red blood cell clots are. So the white clots are smaller. They're less dense on non-contrast CT. They're stiffer with an exponential increase in stiffness based on platelet content. They're more difficult to remove, and you need more passes to get them out or get the same TICI score. You generally tend to get slightly worse final TICI scores, and they're often more likely to be found in the middle cerebral artery. So now we're going to come to the interaction between stents and thrombi. So it's more complicated than we originally thought. So it was originally thought that the stent just cut into the thrombus, it grabbed it, it ingested it, and then you pulled it out. But actually, as with many things in life, the more you look, the more you see, and you're often surprised by what you find, rather. So the first study really that I could find that looked at any detail into this, particularly in vivo in patients, was published a couple of years ago by a Japanese group in JNIS. Now they used high-resolution cone beam CT with dilute contrast after the stent had actually been placed at the level of the clot during mechanical thrombectomy procedures. So this is real-time in vivo work that's being done to look at how the stent is interacting with the actual clot that you're trying to remove in the actual blood vessels. So it was quite interesting work, actually. A small study, only 11 patients. And what you can see here in this, one of the cases that they demonstrated is the stent's in place. This was a solitaire. And you can see that in this case, the stent is fully opposed, but some of the clot has been pushed out to one side, some of it's ingested here, and some more is ingested here. You can see there's the clot there, there's a bit more clot there, and some of the clot sort of squished out into the side branch there. Here's another case where actually the stent is not fully opposed to the vessel wall. It's compressed here where the clot actually is. And so the clot is actually trapped between the stent and the wall. So it's not inside the actual stent retriever, which was what was originally thought. Not sure why the rest of this picture's not there, but they got Ticky 3 on the first pull. And interestingly, they only found complete expansion of the stent in 1 out of 11 cases. So complete expansion of the stent appears to be a rarity, a bit of an oddity, rather than the normal. Now, that could have been just all of the clots were very different, and they didn't talk about the composition of the clots, but it seems a bit odd that all of, 10 out of 11 clots would have been platelet-rich clots. That doesn't really fit with what we see generally. So only a small study, but complete stent expansion and entrapment of the clot within the actual stent doesn't really appear to be occurring with significant frequency, at least not when you're using your standard solitaires, your Trevos. So the stent-clot interaction is far more complicated than we originally thought. More recently, Autor et al. Performed micro-CT and scanning electron microscopy of clots that were removed by stent retrievers, and they started to assess the actual interaction of that clot with the stent. So what they did was they cut the stent, they placed the stent into a micro-CT with the clot still trapped within the stent. And they decided that there were they observed two types of different interaction. One was a mechanical interaction, which is the thrombus was intertwined around the struts, leaving some space between the strut and the thrombus material. And the other one was a more adhesive interaction. So thrombus coalescing to the stent retriever, much like water to a thread. And here you have these two different types of interactions that they sort of identified. So this is the mechanical type. The clot is intertwined and wrapping around the stent strut. And here you see no real gap. It's adhesive. It's some sort of bond that's formed between the clot and the stent strut. They also noted that the clots were composed mainly of red blood cells. The median red blood cell content there was 87%, and that the surface of the clots was heterogeneous. So just like we said earlier, these clots aren't only red blood cells, they aren't only platelets. There are regions within all clots that are platelet-rich, fibrin-rich, RBC-rich. And you can see here some loose, porous regions next to dense regions. And they noted that the stents appeared to interact more frequently with the dense regions, and that the majority of the interactions with the dense surfaces were of the adhesive type rather than the mechanical intertwining. And that probably makes sense logically. So stents may not fully oppose the arterial wall. In fact, that appears to be relatively uncommon, at least the existing ones. Stent-thrombus interactions are both adhesive and mechanical, and probably there are more different types of interactions even than that. Other work has shown that the stent struts embed into thrombi gradually over time. And so what other groups have shown is that gradual embedding into time is probably more important for stiffer clots. So there's a slide missing, I think, but it's fine. So strategy that deals with all clots and minimizes the risks of distal embolization is going to be one of the keys to first pass success, which is, I think, basically what everyone wants to achieve. So how does the NeVa stent help? Well, it's got a slightly different design to most other stent retrievers on the market, and it has these pockets, let's say, the drop zones that they've called them, and they're quite big actually. And it's got higher radial force than existing stent retrievers, and we'll have some evidence of that, some testing that's been done in comparison to Trevo and solitaire devices. The idea being here is that the clot can sort of fall into the stent. In addition, you have this sort of, like the embo trap and like newer devices, sort of a capture zone to try and catch any large fragments that may come from the more friable, more loosely formed red clots. So here you can see that the radial force, the chronic outward force here of the NeVa T and the NeVa M1 stents is significantly higher than both the solitaire and the solitaire 6 and 4, as well as the Trevo. And those devices are classically thought of as the higher radial force devices on the market. So the higher radial force may help both grab the clot, but also dislodge it. So remember earlier we said that as the platelet content goes up, not only is the clot stiffer, but the friction with the clot and the arterial wall seems to go up. So you want to dislodge it, but if you've dislodged it and you can't grab the thing, then there's no point in pulling it more proximal. It's just going to make your life a bit uncomfortable. So platelet-rich thrombi are stiffer, as we've said before, more friction. Once dislodged, you have to get them inside the stent if you can, and so that's where the drop zone comes into its own. This is a video, unfortunately not animated by myself. I'm not that technically skilled, but this is just to demonstrate from the company the concept behind their device. And one of the things that I'd like to point out is that if you look at the size of the drop zone, it actually matches quite closely the size of your typical platelet-rich thrombus. So the size of the drop zone is about 8 to 10 millimeters. And as we mentioned earlier, the size of these platelet-rich thrombi is also about 9.5 millimeters. So there's no point in having a pocket that is too small, because then you just won't get the action that you're looking for. And I think this video demonstrates quite nicely what the company was trying to develop. So here you will see shortly, and it's captured. And now it's being removed. And we don't need to watch the rest of that. So the animal studies showed that actually the stent retriever, the NeVa, could give very good results in comparison to other devices. So final TICI-2B scores in animals using a variety of different clots, including very hard clots, was actually quite good, and certainly bested some of the more standard devices that we are all familiar with. The largest study to date is coming from Akpinar et al., which is a Turkish study. Standard CT aspect score, as you can see, typical occlusions in the MCA, and quite high final TICI-2B 3 results, not too bad at all. First pass TICI-2B 3 recanalization, sort of 55, 57%, it's not too bad at all as well, quite comparable to many other devices. And first pass TICI-2C3, also not too bad. So I've looked at our results so far, and they seem to be better, although very small numbers at the moment, but they seem to be better than the results that are published so far. So we've got 10 cases that have been enrolled into the NeVa 1 registry so far. We did do a few cases as roll-ins, so we learnt how to use the device. I haven't included those in this, just the registry included cases. The majority are M1 occlusions. We've got an ICA occlusion as well as a basilar recently done by Mohammed. First pass TICI-2B or greater is 90%. Final TICI-2B or greater is 100%. And first pass TICI-2C3 is 80% so far. And you've only needed 1 to 2 passes, so median number of passes is 1. And here is just a sort of very typical case, a mid-M1 occlusion. And as you can see, here you can see these markers for the drop zones that have been described. There's the proximal marker. I try to still deploy the device with the proximal marker close to the proximal edge of the clot. And as standard, I tend to use a sort of badass technique, so balloon, 5 French Sophia here, pass the device through a headway 21. One of the things that I take quite care with is to make sure that I have the device in the angular artery if I can get it into there. And I don't like to deploy the device beyond really the mid-angular. And the reason for that is because of the higher radial force. I'm a bit worried that if you deploy like into the M2-3 junction or very distal into M2 branches or into the ascending frontal artery, I'm concerned that that higher radial force, especially if you have increased tortuosity, may result in subarachnoid hemorrhages. So at the end of one pass, it's complete restoration, so TICI 3. Like I said earlier, careful to deploy the device in the angular artery, not too distal. I think if you have the distal tip in the mid-angular, that should suffice. If you have let's say a mid M2 clot here, I would not personally choose to use the NeVa device, I think, but for ICAs, for basilars, for M1s and M1-2 junction, I think it's a very good device. Generally, I tend to pull in the same manner. The company recommends a sort of start-stop technique. I just tend to pull slowly and steadily after 5 minutes of embedding, and it seems to work fine. Now, this is quite interesting, and we haven't actually got any experience of this yet, but we're hoping to receive this device early in 2022. So this is the NeVa NET, and it's designed to try and limit distal embolization. And it looks like there's like a ball of flow diverting material there, a sort of net to try and capture any distal thrombi, which I think is actually quite a good idea, and it goes a little bit further than the EmboTrap design, and I think other companies with the Daisy from MIVI, for example, are looking at ways of preventing distal embolization. So basically, this is just a general slide. If you're thinking of going for something, try and consider a NeVa first. That's it. Thanks very much, and I'd welcome any questions.